Welcome to the X-ray presentation. So we'll pretty much focus on chest X-rays overall for this presentation. So I do have another chest X-ray YouTube video that I will try to link in your resources as well. That sort of goes over my personal technique and different ways to read through the X-rays as well. So I strongly recommend that one if you haven't looked at that one before. It's called Chest X-ray Evaluation, and so that's something to look at. I sort of cover some of the same stuff here, but this one's going to go into a little bit more detail, and that other one's just a good place for just basic ways to look at different types of X-rays. Alright, so pretty much the history, when we're looking at the history of these X-rays, you're seeing it was invented back in the 19th century, way back when. It's Roken is the guy that invented it. The reason why there's the X in there is because the X was an unknown. X was the unknown, so they were very mathematical about it. Good job. Some countries, they call them Roentgen radiations. This is X-rays. Obviously, X-rays is what took precedence mostly out there. Not reflected like light rays, but they penetrate most matter. And based upon the type of matter the X-rays are going through, it's going to show up differently on the film. So it depends on the density. The more dense it is, the more it's going to absorb the X-ray. So let's say I have this really dense, thick brick here, and then I have all these X-rays that we're just going to shoot at this, and then I have the X-ray film back here, or nowadays it's a cassette, but I have the film. Because it's so dense, will the X-rays be able to get through that material very easily and go and hit the film? No. So hardly any of them will go through there, and therefore that's going to be a very opaque or white. It's going to be very dense. Now, if I have the sort of the similar situation and I have something sort of see-through, and I have, you know, the X-rays going through it, let's say it's a cylinder or it's a hollow brick instead of just a pure brick. It's a hollow brick, and so more X-rays will be able to make its way through and go to the cassette, right? And then that's going to appear darker because less X-rays were absorbed. Over here, we had greater absorption of X-rays, and therefore that's why you're not going to see it as dark. Over here, on this scenario, this lower one, where we have the hollow brick, there's less absorption of the material, or less absorption of the X-rays by the material, and therefore most of the X-rays will hit, and therefore it's going to appear more radiolucent or dark. So dense objects such as bone absorb more X-rays and allow less penetration, like this example we talked about here with just a solid brick, compared to objects that are filled with air, like the lung tissue, which is like this sort of hollow brick, right? We see a lot more of it going through there, and therefore it's radiolucent if it's more hollow. So those are the big things to remember. X-rays that pass through a patient are absorbed by a film. Of course, now most days they use a cassette. This X-ray is, as long as it passes through low density, it creates it being very dark or radiolucent. Some people call it like Lucifer, dark, right? That's how they remember it. Whatever works, right? Fewer X-rays strike the film, that means it's going to be radiopaque. That means it absorbed most of the X-rays, so that means it's very dense, and it therefore appears more opaque on the X-ray result there. So obviously, more digital imaging processing with cassettes now. So modern times, cassettes usually can be digital, and we'll almost see an instant result, especially bedside. They'll do a portable AP X-ray, and you can actually see the results at bedside. And then it'll be uploaded into computers, so then you don't have to go to the special room that has all the X-rays. You can just pull it up on almost any computer in the hospital most of the time. A lot of advantages now that we have is we can use magnification on these X-rays. We can change the contrast, we can invert it, we can do a bunch of different things with our modern ways. The old ways, they really couldn't do that a lot of times. One major flaw is you need to remember that this is a two-dimensional picture of a three-dimensional object. In other words, you got to keep the subjectivity in mind. You got to keep that in mind, that you're looking at a 2D picture with a 3D object, and therefore it can make it a lot harder to interpret. And that's one of the reasons why X-rays are not something you can just get right away. It's more of an art than a science, is how I usually describe it. You got to practice at it and practice at it and practice at it before you really get to the point where you can see most of the things that you're supposed to see. So I encourage you, when you're out there, when you see a doctor, and that's how I spent a lot of my time in the ICU, is that if I see a doctor, go do a procedure. If I see a doctor, go look at X-rays. I'd be like, hey, just tell me what you're looking at, right? What do you see, and how do you go about it, right? You're going to learn so much more that way, and then the more exposure you see, the more you will see. More little things you'll be able to pick up, and the better you'll get at it too. So don't be frustrated initially. It's an art. Alright, so we're looking structures on the same horizontal level produce the same shadow on the image, whether they're inside or outside the body. So if someone had a coin taped to the outside of their chest, either in front or behind them, it's going to look like the same shadow as a coin lesion lung mass that you see in this picture. So look at this bottom right picture, right? You see that little coin lesion down there. So we don't know if that's in the lung and that could be a tumor, or if that's something that's in someone's pocket or part of their shirt or something like that. So that's something that you just got to keep in mind. There was an X-ray at a conference, and the doctor pulled it up. He's like, tell me what you see. And there was just nails, like from a nail gun, like all over this person's thorax, and he's like, what's going on here? And he's like nothing with their lungs. This was all in their clothes, because I guess they fell down at a construction site, and there was all these like nails and screws and stuff all over the place, and it was just sort of in the clothes and jacket and all that stuff. So it was pretty interesting stuff. So just be aware, some of the stuff could be on their clothes too, and that's why you might see some things that are unique here and there, and just sort of keep that in the back of your mind, that that could be something other than what's inside their body. It could be outside their body. So low density tissue like lung parenchyma should be dark on the image. Right here you see your moguls, your three moguls, your aortic arch, your left atrium and left ventricle. And you see how dark this tissue is. This is a great example of like a clear chest X-ray with maybe a coin lesion, or whoever knows what that is. But that's what you're looking for. You want to see very radiolucent. Overall, dense tissues like bone, like you see here in their shoulders, their clavicles, all that you want to see radio opaque. So never delay fundamental treatment. This is something that I will test you on. I'll give you a situation where it looks like the patient has a massive pneumothorax, right? I'm just giving you an example here. And everything appears like a pneumothorax. So instead of delaying and waiting for an X-ray to confirm it, you're going to treat the patient. I hope that makes it simple for you, right? If there's obvious signs of hypoxia, cyanosis, anything like that, terrible saturations, heart rates, variable dysrhythmias or arrhythmias, sorry, all that bad stuff is going on, and there looks like a pneumothorax, you're going to treat the pneumothorax. You're not going to wait for the chest X-ray. Now, if the patient's stable and all this other stuff, and they don't have terrible SADs, they don't have a bad blood pressure, they don't have anything like that going on, then maybe a diagnostic X-ray. But overall, they're going to want to know, if you know that there's a pneumothorax, are you going to wait to treat it while this patient dies in front of you, or are you going to treat the patient for a condition that you know they most likely have? And that's what they're trying to go for. Like I said, this is an NBRC thing. Sorry, a board exam thing. I didn't say those four letters. This is a board exam thing, and so that's what they want to know. If you have the skills to look and see what a pneumothorax looks like, and do you know that you should treat something that's emergently? That's what they're looking for. And so I'm going to do the same to you, right? I want to see if something's emergent, you're going to treat it emergently. If something's not emergent, then you're going to treat it non-emergently. Straightforward, I hope, anyway. So tension pneumothorax means usually there's a drop in their blood pressure, right? So it might not even be time for an urgent chest x-ray. They might have to be put in a needle or a chest tube just based solely on what you see at the bedside with tracheal deviation, unilateral breath sounds, drum-like percussion note, boom. Right? So you should be familiar with the indications for chest x-rays, but understand if the situation's emergent or not emergent, and that's going to help you on exams down the road. So what are some indications? So pathological changes, right? See if there's anything going on there. We talked about that a lot in disease class. And then are we going to do the appropriate therapy? Is there lots of mucus and opacities in there, or is it mostly atelectasis from just hypoventilation, like passive, right? So this is something that you need to look at. Are we going to do just volume expansion, or are we also going to do airway clearance therapy? So the x-rays can be very helpful there. How effective is that treatment? 24 hours later, get a repeat x-ray. Let's see what's going on with that patient. Tubes and catheters, especially endotracheal tube, chest tubes, OG-NGs, central lines, all those things are going to be very, very helpful. So if someone puts in a central line, is that an indication for a chest x-ray? Yeah, line placement, right? Same thing, intubation, line placement, sort of, right? ET2 placement, right? So that's one of the things that we want to look at here. And we can also see the progression of lung disease, if it's getting better, getting worse, if we should add stuff. It's pretty cool stuff. So it can give you a lot of fun information. Sometimes the information is more fun, like you see in this bottom x-ray, than no. You can also see after an invasive procedure how they did, especially like bronchoscopy. If we got samples, if we did forceps samples, there's a chance they could have a pneumothorax or anything like that. You can see if there's things in there. There are some surgical procedures where they have to take an x-ray to make sure they didn't leave anything in there. Just saying. So different indications for it. When we're looking at different views, board exams will ask you about different views, therefore I will ask you about different views. PA, lateral, are some of the views. PA is going to be, and then there's AP, of course. PA is going to be your very diagnostic film. That's where the patient stands with their back towards, and it's like 6 feet away, and their back is towards the X-ray machine, and their chest is against the cassette. And then a portable x-ray, an AP, where they come into your room and the patient's sitting in the gurney, right? That's where, and the cassette is behind their back and the x-ray is in front of their chest. And so that's going to be an AP. And there's a difference between the two, and we'll talk about there. And then the laterals. Laterals can be very helpful, especially in obstructive lung disease patients as well. I've even seen lateral be super helpful with neonates when we're looking at like small pneumos, especially because those little babies can get spot pneumos pretty easily, and you might not see it until you see the lateral x-ray. Patients instructed to take a deep breath and hold just before the x-ray is taken. Of course, if they're on a ventilator, that may not be something they can do. Once it leaves the source, it'll strike the patient's backside of their chest, moves through their chest, and exits through the front side. So this is what they call the PA, right? A posterior anterior. It starts in the posterior part of their chest, right? And then it exits the front part of their chest. So the first word in the orientation is where the x-rays hit first. The second word is where the x-rays exit. So it enters in the posterior part of the chest and it exits in the anterior part. So that is a PA film. So their posterior is facing the x-ray, their anterior is facing the film or the cassette, right? So an AP means it's coming through the anterior, right? Because it's anterior, posterior. So it's coming through the anterior part of their chest, and it's exiting the posterior part of their chest where their back is laying against that cassette, right? So you sort of know the difference there. So when we're looking at these views, the heart should be in the anterior half of the thoracic cage. So therefore, if we take a PA film, and I love this picture down here, if we take a PA film versus an AP film, you'll see the heart look much bigger in the AP side versus the PA side. So there's a lot less cardiac magnification with that PA view. So it's a lot better diagnostics as far as looking at things like the bases and all other stuff. Does it mean it's useless to get an AP? By no means, right? But if we want just the most clearest, perfect picture possible, that PA is going to be perfect. Generally, a left lateral view, that's where they're going to have the patient put their left side of their rib cage against the cassette. That means it's going to go through the right side. Is a good way to do the lateral picture. Left lateral view provides less cardiac magnifications because remember, the heart is closest to the cassette if their left side's against the cassette. So therefore, we're going to see less cardiac magnification and a better picture of that right lung overall. So usually you're going to see the patient a little bit turned. If you've ever had this done on yourself, you're going to see the patient turn just a little bit, like 5 degrees, just the tiniest bit, so that way it avoids some of the lung shadows. It's a lot easier that way. So this is just a different way of picturing a PA versus an AP. In AP, remember, it has bigger cardiac magnification because the heart is closer to the X-ray machine. Right, and plus these things are only about 4 feet away, and then in the PA, these things are about 6 feet away. So much further back, therefore a lot less magnification of the heart. Not only that, but the heart is closer to the cassette. The closer the cassette it is, the less magnification it's going to be, therefore a better diagnostic image. So, I have lateral decubitus here. I love these. Lateral decubitus is where the patient will be lying down on their side. And then we're looking for a fluid-filled pleural space, or we're looking for a small pneumothorax. Let's change to yellow here. Here we go. So you can see how there's a bunch of air up here, and then down here is the lung tissue. So I'm highlighting the lung tissue, and then I just outlined all that air. And so you can sort of see that that whole area, it actually was able to show a pneumothorax more effectively with the patient actually lying down. It's pretty cool. And then over here on the picture on your left, you see this meniscus sign. That's called a meniscus sign, right? And then you can see this whole area is just filled with fluid, right? That's that pleural fusion, and they can actually see it a lot easier on a lateral decubitus. So if they're suspecting a pleural fusion, the X-ray that you would want as far as board exam is concerned would be that lateral decubitus, right? Usually you can see pretty small volumes here, so it's going to be a lot more sensitive than an upright film. A pneumothorax, they should be placed on their opposite side. So if they're suspecting a right-sided pneumothorax, like you see in this picture on your right, if they are suspecting a right-sided pneumothorax, then you're going to put the patient on their left side dependent, right? Left side dependent. If they suspect a pleural effusion, you're going to put it on the same side. So if they suspect a left-sided pleural effusion, you're going to put the left side dependent. Right, even though this is the right side. If this is a right-sided pleural effusion, then they're going to place the patient on the right side dependent. In other words, lay him down. So if it's a pneumothorax, place him on the opposite. If it's a pleural effusion, put him on the same side. That's because air rises and all of that, but gravity will help you with the pneumothorax. Because remember, all the dense lung tissue will fall, and therefore you can see it a lot better. With pleural effusion, remember that's fluid, whether it's dense or watery, depends, transudate versus exudate. When you're looking at that, that's something that you got to have in mind. So if it's fluid, place them on the same side. If it's air, place them on the opposite side. Alright, so apical lordotic. This one is a classic one they'll ask, especially if there's a coin lesion. So it sounds like I'm going to ask you very similar things here. So an apical lordotic view is we're going to have the patient, and you'll see the picture on the bottom left, where the patient's sort of in that slash type state. They're going to be doing that so that way they can get the clavicles out of the way. So if you look at the picture on your right, that X-ray on the right, you're going to see the clavicles are way up here. And so that means that there's something like a suspected coin lesion and they don't want to do a CT scan, then they can look at an X-ray in this view and might be able to identify some apical issue that could be going on. So this is an option as well. So it sounds like I could ask you about this. If there's something the APIS sees they want to view and they don't want to do the CT scan or it's broken, what view would you recommend? Well, which one gives you the best picture of the APIS sees? The apical lordotic. Alright, so expiratory view films, this is something that's out there. Even though they always tell them to take a deep breath for most of these films, there are times when they might actually tell the patient to exhale. If they have a small pneumothorax and we have them exhale, there's more gas in the pleura, or there's more space in the pleura than there is if they're in full inhale. And so it actually might accentuate and help us tell where the pneumothorax is. So it might be able to do it on an expiratory film a lot easier than an inspiratory film, right? So it will occupy a greater percentage of the thoracic volume and stand out a little bit more if we have them exhale if it's a small pneumo. So if we have someone that has a spont, small pneumo, like tall, thin individual, and they have that apical pneumothorax, that can happen, they might have them actually do an expiratory film. So it depends on the radiographer, of course, but in this position, the lung tissue is also going to be denser because remember, as you exhale, lung tissue collapses towards each other, and so that will also help identify that area of pneumothorax because lung tissue is going to be more dense, and therefore you're going to have more contrast to see the dark air in the pleural space. Pretty cool. Right, so this is an inspiratory film and expiratory film that you're looking at here. This is great for pneumothorax or to see if their air trapping is improving or getting worse. So if you have a patient with severe air trapping, you can actually see that there's a change in volume or bigger change in volume on inspiration versus exhalation. And that can be a very, very positive sign in this situation. So that's something that you could be looking at. Portable chest x-rays, that's what we were talking about. These are usually APs, and these are usually only about like 4 feet away from the patient. Remember, the heart looks bigger in an AP film, but it doesn't mean it's useless, right? We can still see a lot of information. The cassette's behind the patient's back, and it'll go from anterior to posterior. Usually, like I said, 4 feet away from the patient. That's also a sputable question. That's just something to remember. So there's more magnification an artifact than compared to a PA film. So which one of these has less magnification artifact? The PA film. Which one of these has more magnification artifact? That would be the AP, right? So remember those differences, right? How well the tubes are positioned. We can see their ET tubes in correlation with their carina. That's not going to be changed with AP view. We can still see their central line if they caused a pneumothorax with the central line, like a subclavian. We can still see if their OG tubes placed correctly or NG tubes placed correctly. So there's still a lot of valuable information. We can still see if there's a lot of atelectasis. We can still see if there's a lot of stuff going on. Especially with invasive procedures with an AP film. So it's not incompetent in what it can do. Alright, indications, of course, new onset of dyspnea, cough, sputum, fever, chest pain, coughing up blood. Those would be indications for an x-ray, of course. Other things, too, if someone has a history of chest trauma, we want to see if there's broken bone. Of course, if we think someone, especially kids, aspirated a foreign body, but I've also seen adults aspirate foreign body, especially during joking time with teenagers, adults that may have swallowed something while they were laughing or talking. So foreign bodies can see if it's radiolucent, or if it's radio opaque, then we can see it. If it's not, then we might not be able to see it. History of tuberculosis, we can see if their TB is active or latent. We can see those granulomas and the apices, things like that. History of COPD, of course, we could see if they popped a bleb and have a small pneumo, things like that. People with smoking histories might be a good idea to sort of see if there's any new disease that's developing. A history of pulmonary fibrosis, we could see if their lung volumes are being even more reduced, and or pulmonary hypertension could be causing cardiomegaly or right-sided heart failure, so right ventricular hypertrophy in this situation. And then it could also happen if they're employed with dust and fumes. So that way we could see if they're possibly developing an ILD of some sort. So we'll look for things like ground glass opacities and whatnot. More indications, there's lots of indications. So x-rays are going to be very common currently. If someone has abnormal lung sounds like crackles, wheezes, a sudden drop in blood pressure on mechanical ventilation, what do you think that could indicate? Sounds like I could easily ask you this question. So hint, this would be associated with higher peak airway pressures, a sudden increase in peak airway pressures, and if you did a plateau, a sudden increase in almost equal plateau pressure. Odds are they may have a drum-like sound on one side of their chest. Right, this would be classic signs of a pneumothorax, right? So unilateral lung sounds. So that would be something where it'd be like, is there a mucus plug, pneumothorax, pleural effusion? What's going on there? They're working hard to breathe. Patients working hard to breathe. No matter what, if it's cardiac or pulmonary, we need an x-ray just to make sure. If not, rule out things. Respiratory rates over 30, so tachypnea. Of course, loud heart sounds, so P2. S1, S2, P1, P2, right? If they see edema on their feet and ankles, right? That's one of the things that could be indicated because we're looking at cardiovascular function. If there's a murmur or anything like that, or any signs of trauma, x-rays are going to be very useful for us. ABGs, if they have a severe hypoxemia or hypercarbia going on, and or both at the same time, x-ray definitely would be indicated because that could help us figure out what's going on with this patient. Pulmonary function test. Post-procedure, especially when we're looking at the procedures, especially something like a bronch that we talked about before that had forceps or needle biopsies, that's going to be something pretty important. Or after a central line has been placed, or after an ET tube has been placed. And there's a bunch of other reasons too. Pulmonary function testing. That's one way to look at if a patient cannot give you good effort. In other words, let's say the patient had a GBM, a glioblastoma meningioma, like a brain tumor situation, then that might be the patient might not be able to mentate enough to look at pulmonary function, so they might get a chest x-ray instead. More indications, there's lots of them. Evidence of air trapping, like they had a high FRC or high residual volume for some reason. Maybe we'll get an x-ray to sort of see what might be causing that, whether it's a one-way valve, mucus plug, or air trapping. What's causing their air trapping, right? If they have low flow rates or volumes, a low DLCO, those are all reasons why we might need to get an x-ray and sort of see what could be causing it to be more specific. And a lot of times the x-ray, like I said, is more to rule out things than it is to find things. Post-procedure, we already talked about that. Intubation, line placement, chest tubes, post-thoracentesis, obviously pre-thoracentesis, otherwise how do we know? Pericardiocentesis, right? Make sure we didn't destroy anything there. Bronch with a biopsy, we already talked about that. A needle biopsy of the lung, like an open lung biopsy. And finally, anything that involves abdominal or thoracic surgery, they're going to do an x-ray just to make sure everything's still looking good. Increase in PIP with volume ventilation during mechanical ventilation. So this usually indicates a higher airway resistance. So let's say the plateau pressure stayed the same, but your peak airway pressure increased. So that's usually an increase in airway resistance or RAW. So what are some things that can cause an increase in RAW? Well, bronchospasm, foreign body. Trust me, that's happened where they've had a foreign body that's moving around in there, and as it gets more proximal to the ET tube, then their peak airway pressures will go up. Bronchospasm, of course, pulmonary edema, can cause a change in both your compliance and raw, but with pulmonary edema, you can get bronchospasm. So that's something you got to be aware of there, that bronchospasm component to it. I say these things because I've seen these things. So be aware. You see sudden acute changes in the pips, and it's not secretions in the tube or something wrong with the tube itself. Remember your dope pneumonic, dislodgement, obstruction, pneumothorax equipment. Go through those, right? You know that that those things, none of those things are causing the changes in your PIP. An X-ray might be a good idea. Post CPR, of course. Oh heavens, yeah, a lot of things could have happened during CPR. Line placements, especially ET tubes, central lines, you name it. Broken bones could have happened, chest tubes could have happened. So yeah, post CPR definitely for sure. Routine for mechanical ventilation patients, it sort of depends on facility to facility here. Some people will get an X-ray every morning for the first 4 days, and PRN after that, but it just sort of depends. Just to sort of trend if the lungs are getting better or worse while they're on mechanical ventilation. And then routine screening for infectious diseases like tuberculosis. I think it's like once every 5 years, things like that. All right, evaluation. We talked a little bit about this. Is making sure that you see your landmarks on these. So looking at their history and physical can help you sort of pinpoint what's most likely you're seeing on the X-ray when you're looking at it. So don't forget looking at why they're getting the X-ray, right? This is a good figure. I think this one I took directly from your Wilkins book, and so this is just sort of highlighting the primary landmarks that you would see, right? You see your carina, your first rib, right? Follow your first rib down, and then you count from there. So you want to be able to sort of see these things and be able to recognize them. The better you are able to know your landmarks, the more you are able to benefit from their X-rays, because then you sort of know exactly where you're looking at these things and what you're looking at. You get that more of a 3D image in your brain of this 2D scan. All right, the systemic approach. So if you're listening to this and you haven't seen my previous YouTube video, the chest X-ray evaluation video, please go look at that. I go into detail about a systemic approach to looking at X-rays, and hopefully that will be helpful to you. And then this is sort of, I'll just brush on it a little bit here. But the first step is to determine the quality of the image. When you're looking at the image, begin with. The first real step, I'll do step 1A, is going to be make sure you have the right patient and the right birthday. Right? Make sure you have the right patient. Right? Does the patient's name and birthday match up to what your patient's is? There's so many John Smiths out there, right? So that's where you just need to make sure you got the right person. Okay, step 1B is making sure you have a good quality image before you interpret it. And so how do you make sure you got a good quality image? Well, you're looking at the vertebral bodies. You should be able to see the vertebral bodies through the cardiac shadow. If you don't see them, then it's underexposed. If you see them very, very clearly, then it's overexposed, right? So if the vertebral bodies are easily seen, it's overexposed. The X-rays penetrated too far through the object. You're not actually seeing things that would show up normally, radiopaque, are not showing up, right? That's what's going on here. Underexposure makes identifying the vertebral bodies more difficult. That means that the X-rays did not penetrate far enough into the thoracic cage. And so everything's going to look a lot more dense, a lot more radiopaque than it actually is. So we could think a patient's condition is worse than it is clinically. So when you look at the X-ray, you got to be like, hey, what's the quality of this film before you start making changes? Right? So here's an example of overexposed versus underexposed. On the picture on the left, you can't even see the vertebral body, so that means everything's going to look more radiopaque. It's going to look more dense. It's going to look more allostatic. It's going to look more closed down. And then on the right, you see it's overexposed, right? The penetration was too far, and that's why things that could normally, there could be a coin lesion here for all we know, but because it shot so far through, we don't know, right? Normally it would show up, but it's not showing up here, so we could miss some important things, and that's why the exposure is a pretty important thing to look at. So if we're looking at something that needs that exposure, we need to make sure we got the right exposure if we're looking for something. Alright, so after we look at the quality, you need to make sure they're not rotated. So one lung would be darker than the other, so that's a sign of rotation. The mediastinal structures will look a little bit different with rotation. The vertebral volume column in relation to the clavicles should be evaluated. So you should see between the clavicles and right behind the trachea. So you should see the vertebrae right behind it, or pretty much stacking through the trachea. So we'll do an example here. Right here, the clavicles were asymmetrical, right? One's higher than the other. On the picture on the left, you see how low this one is and how high this one is. That's asymmetrical. So that's a sign that the patient was rotated and therefore can alter the image, right? And over here on the picture on the right, you see this patient is pretty straightforward because these are almost directly even, right? So a lot different as far as that's concerned. And then not only that, but you can see the vertebral bodies. You can see the tracheal shadow is pretty straight. Now I can't draw straight, but it's pretty straight compared to over here. You see the trachea is actually deviated to one side too. So that's a big difference because of the rotation. That changes sort of how we see things, especially when we're looking at things like lung volume. Especially look at this patient's right lung. Okay, big difference between 1 and 2, right? Big difference in the cardiac shadow, big difference, right? All right, so we looked at the quality of the image, we looked at for rotation, and now we're going to look at their inspiratory effort, and that's why we count posterior ribs. Posterior ribs. Hopefully you remember that. Posterior ribs above the diaphragm. Identify rib 1, remember that's the big circle one, and then go down from there. On a PA image, you should see roughly about 10 ribs for a good inspiratory film. Poor inspiratory effort, the heart is going to be pretty much look bigger than it should be. And then you're going to see a lot more density, of course, because they did not breathe as deep as they could, so there was still atelectasis or lower lung volumes, and therefore you might think they have more restrictive process than normal. Alright, so here's a good picture. On the left you see and the right you'll see them counting the ribs, and these are PA images. Full inhaled images, right? So find rib 1, which is the big circle one up there. And then 2, 3, 4, 5. And we're counting posterior. 6, 7, 8, 9. And then 10th rib right there. So when you're looking at this, if it goes up like a McDonald's arch, it's posterior. So think about the thoracic cage. If you remember to our skeleton in the lab at Pima, the ribs curve up posteriorly and then they curve down anteriorly. So you see these little shadows here that curve down? You see those? Those are anterior ribs. So you're seeing the very shadow of the anterior ribs that curve down. But if it curves up like the start of an arch, that's a sign that it's in posterior ribs. So that's a good way of sort of looking at it there. When we're interpreting the film, normal lung tissue should have low densities, should be radiolucent. As it consolidates, it gets more dense. Abnormalities that decrease density, of course, if there's more cavities or blebs, this creates those radiolucent areas, and that's what we would see with emphysema would be the big one to look at there. All right, and here's a big picture. You see all these areas here, and I'll try to circle them for you. I hope this is helpful. And you can go back through and look at these on your own. Of course, you guys have access to the PowerPoint as well. And you see all these areas, and those are just signs of areas that have been just radiolucent, that are just destroyed tissue. And from emphysema. And you can classically tell this patient's hyperinflated as well. A, tall, thin, narrow heart, remember that from disease class. And then B, look at the CP angle. This is not an arch. This is just barely a little dent. Usually you want to see a good quality arch. Here, this is not a good quality arch. That means these diaphragms are flattened, right? This is a sign of large lung volumes or chronic hyperinflation. So density. Water densities appear as like gray shadows. Heart, major blood vessels will show up as opaque. The structures allow a clear view of any deviation from normal position and size. So it's a good thing to sort of look at heart position too, especially if there's a pneumothorax or pleural effusion, see if there's deviation that's going on. Alright, so this is a pretty cool picture. What do you notice here, right? You see a pretty clear delineation. Good CP angle down there, but you see how there's that pretty clear socked in picture. So when we're looking at this, the trachea, you see how the spinal, go up to the trachea real quick, and you see how you can see the spine is processed through the trachea? You see those dots that are lined up in there? That's the spinous process. That means the rotation was not there. In other words, there's no rotation. What about penetration? Can you see vertebral bodies through the cardiac shadow? And you can, right? I'm highlighting the areas in between the vertebral bodies. So you can. So it's not overexposed. It's not underexposed. It's not rotated. So there you go. So we're looking at a decent quality image, right? Patient wasn't rotated. No consolidation. Note the consolidation in the right lung, the infiltrate the right middle lobe, because the right heart border is blurred. So if you do not see a clear delineation between the heart border, then it is the right middle lobe, okay? If you do see a clear delineation, then it's a right lower lobe. So if you see heart border, it's lower lobe. If you see the border, it's a lower lobe. And I memorized this the weird way. There used to be a place called Borders. They were a bookstore. And they went bankrupt. And so that's why I knew that if you see a border, they're below. They went bankrupt. But that was just my own personal way. You might think of a better way to think of that. But it's the right lower lobe. If you see the cardiac border, it's the right lower lobe. If you don't see the cardiac border, then it's the right middle lobe. That's the issue. So what about CPT positions? What about postural drainage positions, right? What about all those things when you're looking at right middle lobes, especially with people that have asthma and all this other stuff? This could be an important aspect, knowing if it's the middle lobe or the lower lobe for sure. So this is called a silhouette sign, and we'll get into the silhouette sign. So normal lung, we're going to see peppered opacities because of the vasculature. Remember, there's blood flowing through the lungs, at least there should be. If we have absent vasculature, like we see with blebs or pneumothoraces, it's going to be more radial opaque. If it's bone, it should be pretty opaque. White shadows, indication of evaluation, especially if a patient history shows that they might have broken bones or flail chest, things like that. Some sort of trauma. Now remember, with flail chest, they can do a special x-ray called a rib series, and that might be helpful in those patients. So the big thing here for you guys ultimately is to develop your own system. Now I had my own system. I had the A through I technique that I go over in that other YouTube video. But this one it's sort of up to you. There is no right or wrong way as long as you are able to evaluate everything. Make sure that you pick it and stick with it, right? So there's many different ways to do this, and that's why I'm not going to limit you into just the one that I do. But we just don't want to overlook something that could be important, and that's the big thing. That's why you always want to be very cognizant that you're going through all the detailed steps, right? So some people look at the lungs, then they look at the mediastinum, then they look at the heart specifically, then they look at the diaphragms. I do the A through I, which is the alphabet approach. So that's why I do the way that I do it, and that's how I learned from physicians. So that's just my way. I'm not saying it's superior or inferior, but it's just a way that I know that I've checked all the boxes and know what's going on. Right? Make sure you develop a method that gives you a complete review every time. A through H, I have an A through I, but A through H, airway, bones, cardiac, diaphragm, volume. I also do E for esophagus. That's where, and I go over that in the other video, so you can watch that. So I won't put it too much in here. I also look for an OG or E. I look for a feeding tube to make sure it terminates in the stomach and not in the right right lung. Fine detail, pleura, parenchyma. I look for fissures, especially in that previous picture where we've seen that right middle lobe pneumonia going on. Then you could clearly see that fissure that's right there. Gastric bubbles, any restriction on their lungs, hilar infiltrates, anything like that, like hardware. Eyes, interstitium, where I look at all the different areas, the fine detail and the parenchyma and stuff there too. But there's different ones that are out there, so pick one and stick with it. The silhouette sign, this is where you're looking if the infiltrate is in contact with another structure. So that's why we talked about that with the right middle lobe versus the right lower lobe. Different densities will become more obvious than normal. So the heart border, the aortic knob, the diaphragm, when we have a silhouette side, that means the lung tissue is in contact with the heart border or diaphragm, which means we lose density or contrast. So the right middle lobe is in contact with the right ventricle, the heart, and that's why we did not have that clear delineation in that previous x-ray. So that was technically a silhouette side. Now, if we've seen the border between the right side of the heart and the condensed lung tissue, then we know it's the right lower lobe, and therefore it is not a silhouette sign because the borders were not blurred. I hope that makes sense to you. But if they're in contact, they're touching each other, they become one. Little relationship there. And then therefore it's called a silhouette sign. So here's a picture. We're just looking at the A through I's, or you can use your own technique here. Practice. I want you guys to practice counting ribs and going through your techniques. And this is just a normal chest x-ray. It does have a little bit of infiltration, but it's not too bad. And I just want you to go through the x-rays, whether you use the A through I technique or different technique. I want you to practice this. The more you practice, the better you'll be. And this is a PA film, which is kind of cool. Also, make sure when you're practicing this is good for testing too. Make sure you're looking for things like the penetration of the film, right? Can you see the vertebral bodies through the cardiac silhouette? If I could draw straight lines, that would help me. Should have passed that first grade. Also, look for symmetry, right? Do I see the tracheal knobs through the tracheal shadow? Here's my carina. Am I identifying my landmarks? Right. So things like that. Start going through there. Start making sure you're identifying things and using your technique. The more you practice it now, the better you'll be when you're out. So silhouette sign, the heart isn't in the anterior of the thorax, therefore the right middle lobe is anterior, the right lower lobe is posterior. That's why you would see a silhouette sign if it was the middle lobe compared to the lower lobe. Right, so if they shade each other out or blurred edges, they're adjacent structures. That's why you know if it's the right middle lobe versus the right lower lobe. Why do I make a big deal about that? Like I said, it's going to help you therapeutically with deciding patient position, postural drainage, airway clearance techniques, bronching. It can help you know which area to focus on. There's a lot of benefits to knowing if it's the lower lobe versus the middle lobe. So this is a classic case of a right middle lobe x-ray. You see how the right heart border and the lung tissue are not clearly defined, right? So this is a classic case. This is a PA film, a classic case of a silhouette sign, right? You don't see a clear where the heart border starts and the lobe consolidation is, so we know it's the right middle lobe. So this would be like a right middle lobe syndrome that's going on, or a loculated pneumonia. And this happens with asthma too, where that whole right middle lobe will actually start to close down, but that's a whole separate thing. Not this class though. I can't go over that in this class, but if you want to look that up, pretty interesting stuff. So that way, this is a silhouette sign, right? Because it blurred that whole border. That's what we're seeing here. All right. so what do you think we're seeing here? This is a clear delineation between the border of the right heart. So when we're looking at this, here's a tall, thin, narrow heart, but you can clearly see that border there, right? You can clearly see that border. So is this the right middle lobe or the right lower lobe? So this would be the right lower lobe. See how you can sort of see the difference? If that border is pretty clearly seen, then you know it's that lower lobe. So that's something that you can see and understand that, okay, now we can focus more on the lower lobe and what could be causing that lower lobe issue on this patient. Pretty cool stuff. Air bronchograms, pretty important. Alveoli filled with air stand out if they're surrounded by consolidation. So if you see an air bronchogram, usually means there's an air pocket and it's either surrounded by mucus, or it's surrounded by inflammation, or it's surrounded by mucus and inflammation are going to be the big ones. Swelling, right, that inflammation. So the big thing when you see an air bronchogram, it means that there is an intrapulmonary condition, right? If you see an air bronchogram, that means there's something going on with the lung pathology. Something's going on, right? It doesn't mean that intrapulmonary disease isn't present, right? But that's what we're looking for. So air bronchograms, it's pretty highlighted here in this picture. Boy, this x-ray is very interesting. But when we're looking at this, you see these dark areas here that it's pointing to. Those are those air bronchograms. That means there's probably intrapulmonary pathology going on with this. It's not just the x-ray. Compression atelectasis. When we're looking at compression atelectasis, the big one's going to be pneumo. And of course this one, take a wild guess what type of pneumo it is if it's pushing at the thoracic structure, especially the vena cava, right? You're looking at something that could be causing tension on those great vessels. Or this be a tension. And you can see the outline of the lung. Here's the outline of the lung. You guys see it? So that's the right lung. You can see how compressed that is? So this can happen from a pleural effusion, a pneumothorax, a hemothorax. So a lot of severe atelectasis can go along with these patients, right? That shift of the trachea and the mediastinum, that's something classically the board exams will like to ask you go. Remember, if it happens outside the lung, the trachea is like stranger danger, it moves away. If it happens inside the lung, like a tumor, then it'll move towards it, like atelectasis, it'll move towards it. But yeah, if it's outside the lung, it moves away. Obstructive atelectasis, that's what we're seeing in this x-ray. That means the airway is blocked, like there's mucus plugging or something like that, a tumor, a foreign body. Something's stopping that gas and that fluid and everything from moving. And so this can create a one-way valve effect and hyperinflation, and that's what you see here. Just that hyperinflation on that whole side. It's pretty crazy stuff. Usually it leads to atelectasis of the distal lung tissue, and you're going to have a really bad issue there. So that right side's hyperinflated, because where do you think this patient is intubated? You can see the tip of the ET tube down there. So this patient's intubated. So where do you think, as the ventilator is delivering the breath, where do you think most of the gas is going? Here's the carina. Most of the gas is going over here and hyperinflating and destroying tissue. Boo. That's ventilator-induced lung injury. Just say no. Down here is a mucus plug. You can see, right, this whole area is that hyperinflation distal. That air cannot get out of there. It's trapped. And so everything proximal is consolidated, right? So this whole area here that, right, all this stuff is just consolidated tissue. So we have a massive mucus plugging that's trapping gas into that left lower area and just consolidating that whole rest of the area while this patient continues to get a ventilator-induced lung injury. Oh, this is not good. All right, so hopefully this is starting to come together for you. Post-operatively, you can see some atelectasis in these patients, especially those patients that are significantly obese or of significant body habitus. People that have chronic lung disease, we gotta really watch out for them post-operatively, because you remember you're more prone for pneumonia post-operatively, especially if you had general anesthesia, for sure. A lot of the big things that we worry about is the mucociliary stasis that happens with paralytics, as well as with dry gas that they're getting if they're going under general anesthesia. So those are all things that will, and as well, let's say they had an abdominal or thoracic surgery, they're not going to have a lot of, they're going to be in a lot of pain for deep breathing and coughing. So all these things can lead up to a post-operative pulmonary infection, aka a pneumonia. And so we got to be really prophylactic with our therapy and things that will help the ciliary escalator get back on, right? Retained secretions means there could be obstruction that goes on and affects a lot of regions. So go through your techniques here. Obviously you can see that right upper lobe has something going on. But in this patient, they have like a tumor that's obstructing their right upper lobe. And remember, most of your lung cancers, all that stuff happens in your right upper lobe, right? So this is something that it's obstructing it, and now they developed a pneumonia that's distal, right? It's pretty bad. And so it's even developed that boundary, right? That fissure line. So you can see the right upper lobe just pretty much defined in there. It's pretty bad. So that's obviously atelectasis of the right upper lobe, secondary to a lung tumor. So what are some signs of atelectasis? Remember, physical exam will vary with the amount of lung involved. So a very small little bit of atelectasis, you might not notice anything, but significant loss. You'll see the patient breathing fast. Obviously their breath sounds will be diminished or distant. Vocal firmness, resonance will be very diminished. Cyanosis, of course, because now we have a shunt-like effect in place. And then remember, if it's inside the lung, it goes towards it. It sucks it towards it. If it's away, it pushes it away. It blows. So you're seeing that happen here. So if it's atelectasis, the trachea mediastinum will go towards the affected side. So pneumothorax, air entering the pleural space. This is where it can happen from either in the lung or outside the lung. There's a third option where you have organisms that produce gas that are present in the pleural space that can cause a pneumothorax without a hole in either the visceral or the parietal pleura. Just a little fun side note for you. I know you love those things, but there you go. Attention pneumothorax, that means air, whether it's from the inside or outside, cannot get out of the pleural space, and pressure builds up and it alters blood flow and ultimately airflow. And remember, this is can happen with either an open pneumo or a closed pneumo. So attention does not say that it's always an open. It can be an open or a closed pneumo, right? You can get attention pneumothorax. So let's say attention pneumothorax is, here, let's do this. You have a patient on mechanical ventilation. You decide to give them, let's just say they're an ILD patient, and you decide to give them 8 mLs per kilo tidal volume, and their plateau pressures were 40, and you blew a hole in their visceral pleura, right? That's the one that surrounds the outside of the lung. So that would be a closed pneumothorax. Is it possible that this air can build up and cause a tension pneumothorax? Absolutely. So remember, when you think of a tension pneumothorax, it's not always, a knife that's stabbing and putting a hole in the parietal pleura. Sometimes it can happen with the hole in the visceral pleura. Okay, so hopefully that makes sense to you. Small pneumothorax, less than 20%, we're not going to treat. Usually they're not going to show a lot of physiological signs. So what do we see here? Here's an example of like a pneumothorax in the right lung. You can see the pleural line, and those arrows are pointing to it, so you don't have to have me draw all over this one. And you can see the chest wall is sort of collapsing in. You can see towards the hilar area. Remember, your lungs are introverts. They always want to go in, stay inside, right? So that's where they naturally want to go. And that's where you see that delineation. You can see that border pretty darn clearly there. Pneumothorax, attention pneumothorax. Usually you're going to see extreme hyperlucency. Of course, this is going to be greater than 20%. And this will shift the structures away from the pleural space. So it's going to be on the opposite side. So the PMI, the point of maximal intensity for the heart, would go to the opposite side. So if I had a right-sided pneumo, my heart would sound louder more on my left side. If I had a left side pneumo, my heart would sound louder more on the right side. So when we're looking at tensions, the heart and trachea will be shifted away. This is important because the ClinSims or part of your board exams will pretty much ask you this information. You need to remember it. The pleural line is also known as a deep sulcus sign. So if they talk about deep sulcus sign, that's just the other term for it. The big thing here, if there's signs of a tension pneumothorax, you need to treat this patient. That means immediate chest tube placement or needling, right, followed by a chest tube placement. So when you're looking at this, this is a massive left-sided pneumo. Is this patient on a ventilator? Yes, they are. You can see the Y of the ventilator. You guys see the Y of the ventilator here? Corrugated tubing. Yeah, this patient has a pneumothorax. So is this a closed or an open pneumothorax? It's probably closed, and it's a tension pneumothorax at that. Here's the border of the left lung, right? So that means the rest of this in here, I should use yellow. The rest of this in here is all free air, right? So they need a chest tube, right? And this could be a hemithorax. It's obviously a hemithorax because it's not bilateral. But look at where the heart is. Do you notice the heart has structures have shifted over, right? It's shifted over, and so therefore we can see that mediastinal shift on this patient. Now, keep in mind, if you're looking at the clavicles, they're asymmetrical on this patient. They're not symmetrical, so that could show some rotation as well. But keep in mind that with this pneumothorax, it most likely is causing some pressure on the heart. So a chest tube should be probably inserted pretty urgently, if not emergently, into this patient's chest wall, especially if they're on positive pressure ventilation. Hyperinflation, very common with your air trapping processes. Emphysema is a classic one, or in the middle of a bronchospasm, of course, a severe bronchospasm, they can get that hyperinflation. Obviously the heart, that's why we talk about that just tall column, narrow heart, right, that you'll see with these. Their AP diameter, especially their retrosternal airspace, can be enlarged. And you will see that with the lateral flattening of the diaphragm. Remember, you want to see those good, like McDonald's arches with their diaphragms. If you see this, where it's just this angle, right, that flattened angle, that's a sign of flattened diaphragms or a flattened hemidiaphragm. This would be a sign of hyperinflation compared to these nice arches that you should normally see. But when you're looking at things like COPD, your PFTs are going to be way more accurate and more quantifiable for their lung function than just an X-ray. So what do you see here? Look at this CP angle. See how it's flat compared to this nice arch, right? So these are flattened hemidiaphragms, which is a sign of hyperinflation. Right? You see how the heart is tall, narrow, thin. You also see multiple air bronchograms in here. You see a lot of issues going here. Hopefully there's a lateral. There may not be. There's a lateral. I love the laterals. And here you see the retrosternal airspace. Do you guys see that? Outlining that. So that's a sign of that increased AP diameter. Right? And here's your depressed diaphragm. Poor depressed diaphragms. They should cheer up. Hyperinflation, do you like how there's a barrel chest there? Little RT joke. So when we're looking at physical exams, barrel chest can obviously be a sign. Percussion notes are more drum-like, hollow, right? Breath sounds are very diminished because there's not a lot of air moving. It's trapped. So if it's not moving and it's trapped, you're not going to hear very good breath sounds. Low diaphragms, of course, wheezing may not be present with emphysema because of just the destroyed tissue. Obviously prolonged expiratory phase because they lost elasticity. That's going to be a big thing there, as well as their tubes are floppy and they'll have premature closure, so it's going to take a lot longer to exhale. Obviously they'll be breathing faster because of the issues going on. Accessory muscles will obviously be involved because they're working harder. So this is one of the things that we're looking at. The retrosternal airspace is one of the big things that they like to look at if they're looking at an x-ray for someone that has things like emphysema. The larger the retrosternal airspace in general, they also quantify that or equate that to the more severe their emphysema is, and that's something that they like to track. ILDs, remember there's over 200 different ILDs. One of the classic things these patients have that just dry, non-productive cough, GOE, and then their big thing with the ILDs is their role and their history. So what is their exposure at their job? Where do they live? What do they do? And that's going to play a big part in us looking at this. So things that they might look at, some symptoms, joint muscle pain, autoimmune. They might look at anything that's autoimmune as well, swallowing disorders. Things like that can help them sort of look at that as a possibility with the x-rays. Different patterns you'll see with ILD. High lymph nodes like sarcoidosis. That's something that they'll be able to see and go in with an EBUS. That would be like an EBUS procedure right there. Usually if the patient's stable enough, but that's something that they could use in there. Diaphragmatic nodules, that's more of your asbestosis type stuff going on. And then we can go in, once again, if the patient's stable enough, and get a BAL and send it for fungal sampling to look for them too. Honeycomb cavities can be seen as well, and that's something that's usually more of your end stage of pulmonary fibrosis. Large air bronchograms usually is a sign of air bronchiectasis. Remember, bronchiectasis is sort of that destruction of tissue that happens in there, and they can get that pink sputum every once in a while from just that those blood vessels blowing here and there. All right, so what do you guys see here? Lots of ground glass opacities. Do you guys see how it looks like someone took a bunch of broken little tiny pebble shards of glass and just sort of threw them on the x-ray, and it just looks like shattered glass, like pebbled glass all over the place? This is a classic sign of either ARDS or pulmonary fibrosis of the chest, right? And so this is a severe interstitial fibrosis that you're seeing here, and that's the GGOs that you're looking at there. So remember, this is a restrictive process, so you're going to see really good CP angles because lung volumes are smaller, right? Count the ribs. How many ribs do you see? All right, so that's the classic ground glass look. All right, air bronchograms, they highlighted them here for you. And this patient obviously has a tracheostomy tube up here. You can see how they highlighted the air bronchograms over here. Hopefully you can see them in there. That confirms intrapulmonary process, right? So this is what's known as an alveolar filling process that goes along with this. All right, bedside. A lot of these patients with ILDs will have rapid shallow breathing. The lung compliance will be very poor, especially if you connect them to positive pressure device like non-invasive or invasive. Crackles, fine inspiratory crackles. If they do a DVNC or airway clearance therapy, they may not change too much because we're looking at more allolectatic situation going on here. Mostly it's over the lower lobes because that's where most of your atelectasis will be. Obviously, there's less surface areas that's being efficient, so they're obviously more likely to have hypoxemia and cyanosis going on. A lot of times after they'll do a bronchoscopy after the x-ray to exclude diseases. So this is where they'll go in and do a BL and rule out a fungal pneumonia or something like that going on, an asbestosis or something like that. So we'll go in and try to rule out some of those things with a BAL. And if all that stuff's out, they'll do a lung biopsy just sort of confirm. And remember, we talked about in the radiology one, the other scans, a radiology one, that they can even use some high-res CT scans in some cases. All right, congestive heart failure. Curly A and B line, something we covered back in disease class, but fluid overload signs, big things you want to look at here. A, heart size, pulmonary vasculature is going to show a lot of fluffy fluid collection. They're going to say vascular filling. with these, and it's usually going to look at a large cardiothoracic ratio is going to be one of your big signs that this could be a fluid overload or CHF. So this is your classic real X-ray where you're looking at this. See how hypertrophied the heart is, right? Big hypertrophy, and you see how fluffy the infiltrates are, especially in the hilar region. It's a classic pulmonary edema. Now this would obviously be a cardiogenic pulmonary edema on this patient. So very, very poor situation. So pulmonary edema, remember, decreases compliance, and so you got to consider that with these patients. They're going to have poor saturations, poor PO2s, poor compliance, and hemodynamics will not be very strong either, and most likely they'll be in a tachycardia. And their oxygen requirements are going to be really, really high because they're in a tachycardia. And so this could easily send them into more lethal arrhythmias, because remember, the heart, not super strong, not super healthy. And so this is something that's very serious very quickly if we don't treat it. Heart size, you're going to see obviously a bigger ratio. And then these are curly B lines, right? They go straight like the letter B. Hopefully you see that, right? The letter B, capital letter B there. And those are curly B lines. Curly A lines are towards the hilar area, and there's sort of these vertical things like the letter A, right? So there's these vertical lines, these horizontal lines, and that would be like the line for the letter A. So curly B lines is more peripheral, and more central would be your curly A lines. Exam findings, they're going to sound crackly. You're going to hear abnormal heart sounds if you guys are into that. And I do have a heart CD-ROM, but those are also available online too. JVD, of course. But remember, JVD can also be present in pulmonary disease with hypoxic pulmonary vasoconstriction. So be careful, just because you see JVD doesn't always mean CHF, right? That's not the only thing JVD shows up with. So just be aware of that. Enlarged liver, hepatosplenomegaly, hepatojugular reflex. Ankle edema is very, very common in these types of patients as well. Okay, pleural effusions. There must be at least 100 mLs present before the fluid can be seen on a chest X-ray. So a transudate, remember, is a clear, watery, low protein content, and more common with fluid overload, especially with CHF patients, lung cancer patients. Usually are transudates that you'll see with these type of patients. So it's just more vascular pressure or low albumin content, right? Low protein content. They're very free flowing. You'll see them best in the lateral decubitus view. If they're asked about which view would be best to see a pleural effusion, you might think about answering lateral decubitus. If it's an exudate, which means it's lots of protein, most likely caused by infection, this blocks lymph flow and it creates loculated stuff. In other words, you move the patient, let's say it's on the right side, and you move the patient left side dependent, or you move the patient around, it's going to stay there. You're not going to see a big difference in there. So that's why we need to sample it to see what the protein content is. And we could also run it for infection. We could also run it and see what type of things are culturing or growing in it too, if it is an infection. So what do you notice here, right? Here's that meniscus sign. This is an upright chest X-ray, right? And you see that meniscus sign. So clearly this would be a loculated? Yes, loculated. So this is most likely an exudate, most likely due to probably infection, is my guess. I don't know much about this X-ray, but that would be my guess. Oh heavens, what do you see here? This is a massive pleural effusion on the whole left side of the hemithorax. So this is what they call a whiteout, and you're just seeing a complete obscurity of all the things on that side. And so that's obviously going to cause a lot of issues to breathing. Now remember, usually they only remove about 3 liters at a time for a pleural effusion. The reason why is if they remove any more than that, and they can, and they probably have, it depends on policy is my guess, but If they remove anything more than that, then they can cause what's called re-expansion pulmonary edema. And re-expansion pulmonary edema means when the alveoli are opening back up, they're creating that suction pressure again. Remember, they're opening back up, so this is creating negative pressure in the alveoli, which means that vasculature that surrounds the alveoli. Remember, like 90 to 95% of the alveolar surface is vascularized. At least it should be. So that blood vessel So that blood vessel that sort of surrounds the outside of that capillary, right, that surrounds the outside there, then there's a bunch of negative pressure inside the alveoli, and then the blood vessel's like, oh, there's a bunch of negative pressure. It's going to overcome, because there gets to be so much negative pressure built up after that pressure is relieved from the pleural space, that it actually sucks some of the fluid from the lymph tissue as well as the blood vessels into the alveolar, into the respiratory zone. So that can actually cause what's called re-expansion pulmonary edema. So just be careful if you start to see someone go into distress after a pleural effusion, especially a massive pleural effusion, has been evacuated. That could be a sign of a pleural re-expansion pulmonary edema. All right, so here is what position is this? Lateral decubitus, right? So this is the person's in lateral decubitus, and then you see all the meniscus signing, and it's pointed. The arrows are pointing right to the free fluid that's going down there. So lateral decubitus, and then you can see how much effusion is there and how big it is. Now remember, if it doesn't occupy more than 20%, usually they're not going to treat it. They'll let it sort of reabsorb itself or take care of itself. So this is not loculated or trapped by anything. So this is most likely a transudate, but you never know. You never know. All right, pleural effusions depend on how much volume's in the pleural space. And over here on this x-ray, you see sort of that, you don't even see that left side of the heart. So it's a decent sized pleural effusion going on there. Small volume is considered less than 20% of the thorax. You'll have a blunted CP angle, a small meniscus sign that you see overall. If it's large, it's going to be greater than 20% of the thorax. Usually you'll see that complete obscuring of the hemidiaphragm, like what we see here in this picture. So obviously that's greater than 20%. So would you treat this one? In theory, yes, right? This may shift the thoracic organs away. So in other words, the heart and mediastinum would be shifted towards the right side if this is on that patient's left side. So a small pleural effusion in this picture has developed, and you can sort of see in the right side, and it's blunted, that CP angle. You don't see a good sharp CP angle, and it's sort of obscuring that right diaphragm a little bit. Do you sort of see this situation? That's called the blunted CP angle. So is this greater than 20% if you just sort of see a little bit obscuring, but like not to the point where it's a completely white out now? So this is something that they may just let reabsorb on its own. All right, consolidation. Bacterial pneumonias can easily cause issues on the x-ray. A lot of mucus production can easily cause this. Other things like aspirated foreign bodies is more common in your children, but have seen adults aspirate a corn dog at a Renaissance fair, right? So these are things you just got to be aware of. Tumors can easily cause this too, especially in that right upper lobe area. Different signs that you'll see here with those patients: loss of volume, homogeneous densities. You're like, oh, something is going on right there, right? Air bronchogram, that can be in that area as well. some of the physical findings. Oh heavens, these x-rays are hilarious. Reduced resonance, obviously not as much air is getting in there, so it's not going to be as drum-like in there. Bronchial breath sounds, more deep tones, of course. Fine crackles, because the atelectasis in the area. Whispered voice sounds are increased, so egophony or whispered pectoriloquy would be whispered pectoriloquy would be present. Same thing with egophony. It would sound like an E and not an A. Tachypnea and fever could be present with this, especially more of the tachypnea part there. Post-procedural is pretty common, especially after intubation. Of course, we want to make sure that's at least 3 to 5 centimeters above the carina, or T4, T5 is what you're looking at there. Chest x-ray should be taken while the neck's in neutral position. So the ET tube should be placed, ET tube placed in the esophagus above the carina might look similar to the same side, but that's why we also use things like end-tidal CO2, the chest wall, bilateral breath sounds, absent gastric sounds, condensation in the tube, so on and so forth. Those are all going to be very, very helpful. And I think it's 1 to 3 centimeters above the carina in a different book, so check your source there. Alright, so this is an AP x-ray, and so what do you see here? The endotracheal tube is located, and it's pointing at the endotracheal tube here, and you can see the radiopaque line. Let's see if I can outline it for you. Does that look like it goes past the carina thing here? Yeah, it goes past it. So what do you think is going on? Obviously ventilator-induced lung injury. Hyperinflation with that one side, destroying lung tissue. Boo, right? You should always be like, foul, foul, right? Obviously this ET tube is main stemmed, right? And so you're looking at this CVP line, is one of the things that you can see here, because the atelectasis is just so strong. It's having an issue with the lines as well, so it's a pretty significant issue over here, so they definitely need to pull back on that ET tube quite a bit. CVP is especially going to be important when we get to the hemodynamics area. You want to see the catheter tip go into the right or left subclavian or into the jugular veins. IJs, EJs are more popular, but you still see subclavians as well. I had a patient not too incredibly long when I was still practicing, not too incredibly long ago, where they put in a subclavian central line. They thought this patient was developing a sepsis, and the physician put in a subclavian, and they actually put it into the artery instead of the vein. And it was pretty interesting because it was pulsing with their heart rate, and they were swearing, even with the x-ray, they were telling me that they were in the vein. And hey, I'm not a doctor, but it looked like it was pulsing, and I drew a blood gas, and sure enough, the blood gas that I drew was pretty similar to the, if not identical, to the arterial gas that we got on that patient earlier. So that's pretty tough because you can't hold pressure on that artery, that subclavian that's in that area, and so that was something that had to be done delicately for sure. So be careful with CVP's placement, especially subclavian, because that could easily cause a pneumothorax as well. So make sure it's in the right place. Could accidentally puncture the lung too, easily go into the pleural space and cause a lung collapse. Yeah, this would be, was it an iatrogenic, right? It would be a procedure-caused pneumothorax. So how would they present? Take a wild guess. What would be some of the signs and symptoms you would see, especially if they were on a ventilator? What would happen to their peak pressures? What would happen to the plateau pressures? What would happen with their blood pressure? What would happen with their heart rate? Alright, feeding tubes, I love looking at these guys because I like to make sure that they don't make a right turn into the right lower lobe. Make sure that they terminate in the small stomach or bowel if it's a DOPOP. they should go what's called transpyloric, which means you'll see the feeding tube go across the spine. If you see the feeding tube, and this is a neck x-ray, but if you see the feeding tube go across the spine, then you know it's what's called transpyloric, which means it goes past the stomach to the pylorus, right? So accidental placement into the lungs can happen. Obviously, they'll be coughing, shortness of breath. They'll feel like they're having trouble breathing, and they can easily develop a pneumonia or pneumothorax. Oh heavens, chest tubes. When we're looking at chest tubes, the proper position is one of the big things that we're looking at on the x-ray, and that can help us with this overall drainage of pleural fluid. You want to make sure that it happens to collect in that gravity dependent area. If it's a pneumothorax, then we obviously want to put the chest tube in a superior area, right? Something that's on the anterior part of the chest where gas rises. If it's something with fluid like a hemothorax or a something like that, then we need to drain it. Then we're going to put it gravity dependent. So what do you notice in this picture? So this is showing a chest tube, and you see the radiopaque line in it. And you see that chest tube, and you see all along the tube, it's thicker in the middle, and it has that radiopaque strip on there. And you can see the edges of the tube, and you can see where it can be placed into the soft tissue and or anything else. So we just want to make sure we're making that we're seeing the tube in the right position. So the big picture, right? The chest x-ray is not only to diagnose disease, but confirm placement of tubes, catheters, and how procedures are working on the patient's lungs. So there's so many diverse applications that makes x-rays so important. So the more you play with these, the more you evaluate, the better you'll get at it too.